right. Well, good afternoon, everyone, and thanks, Jana, for the welcome. I'm a co-worker of Jana's. I'm also a quality improvement advisor with Superior Health. I've been doing this role for almost 3 years now. And prior to that, I worked as a director of nursing for many years and also as an infection preventionist in skilled nursing facilities. So worked through the COVID pandemic, and I think I can relate to a lot of the challenges that you're facing now. Jana explained that there was some material in the first week that you didn't cover. I've revised the slides and we'll cover that material today as well. So we're going to start probably more with some basics on infection prevention and control today. And here's our objectives. We're going to cover hand hygiene. We're going to talk about transmission-based precautions, surveillance, what to do for an infectious outbreak, and how to incorporate QAPI a little bit into your infection program. We'll talk about what your responsibilities as an infection preventionist. And then I'm also going to share some time-saving tips that I used when I was in the role. So this is just kind of a high-level general overview on infection prevention and control programs. As we know, there's just so many aspects to them. You know, you think you've got one thing mastered and there's something else that you need to cover. So just being aware that there are many aspects to your infection prevention and control programs, and that all employees have a role in promoting this safe environment. It just does not fall on the shoulders of the infection preventionist. Infection prevention and control requires teamwork. And the basic fundamentals of infection prevention is your standard precautions. And that was some of the material in last week or the previous week's slide deck. And if you remember from way back when, standard precautions does include hand hygiene, PPE use, proper patient placement, cleaning and disinfection, proper linen handling, safe injection practices, and safe handling of sharps. And during the next few weeks, we will cover all these aspects of standard precautions. But we're going to start off with what I call the basics of the whole program, which is hand hygiene. So what is hand hygiene? It's a broad general term, which is just very simply the process for cleaning your hands. Now in long-term care, we focus on two procedures. One is just hand washing, and the other one is the use of the alcohol-based hand rub, which we generally refer to as ABHR. And part of knowing and having a good foundation for infection prevention and control program is knowing what your facility's policy and procedure says about hand hygiene. So we have a poll question. Jana, if you could put that up. Does your facility hand hygiene policy and procedure state that ABHR is the preferred method for hand hygiene? If you could just answer that for us, please.
Overwhelmingly, we are at 78% saying yes, and a few are unsure, and about 8% no.
Okay, that's great. Thank you, everybody. So hand hygiene is important. It is the first line for preventing the spread and transmission of infections for the residents, our visitors, our staff, and in general for the community. And if you weren't aware, many infections can be transmitted on our hands, and that our residents are very vulnerable and they don't have the immunity, the ability to fight infections. So some of these organisms can be fatal to our residents. And that's why we're continually harping on our staff, wash your hands, use the ABHR. And in addition, some of these things that we can have on our hands, we can transmit to surfaces. And the bacteria, viruses, and fungus can live on surfaces, sometimes for days or even longer. I've got a point on here that says the quality of your hand cleaning and your hand hygiene matters. In other words, you can't just run your hands under the water. You have to follow the correct procedure for doing it. And there's all kinds of CDC guidance out there that talks about how to do hand hygiene, the 20 seconds for the soap and water, how to use the paper towel to shut the water off, when they're using the ABHR, It talks about, how to do it correctly to make sure they're getting all the different surfaces. And if the F880 tag, which is the infection prevention and control tag in the state operations manual, the most frequent reason for getting the F880 tag is failure to perform hand hygiene correctly or in general when it should be performed. And this kind of goes over when you should perform hand hygiene. And I realize this is really basic, but some of these slides you can take and you can use them for staff education as well. So this talks about performing hand hygiene with soap and water when your hands are visibly soiled with blood or other fluids, before eating, after using the restroom. And traditionally, it was for residents that had C. diff or the norovirus. There is some different recommendations out here now that they're saying in some cases you can use the ABHR, but in general, I do believe that hand hygiene with soap and water would be the preferable method. And obviously, if you don't have access to ABHR, soap and water would be entirely acceptable. And that we talked about the 20 seconds. On all the slides that we have here in this slide deck, there is some kind of source at the bottom for them that you can refer to as the source documents. Now, here is the ABHR. It is the preferred method for performing hand hygiene. And that comes right out of the CDC guidance. They feel it kills organisms more effectively and quickly than soap and water. And the other things is generally it's more readily accessible. You need to make sure that you're using a product that has at least 60% alcohol in it to be effective. And as you're walking around your facilities, look at your placement of the dispensers. Are they readily accessible to your staff? Best practice, and if you've had Dr. Buffy in your building from IPC Well, she's going to look to see where your dispensers are located in your residence rooms, inside the door, as well as outside, so that staff can basically foam in and foam out. That is the best practice. You should have your ABHR dispensers at your entrances, your common areas, in your hallways, your break rooms, on the med cards. How are you providing hand hygiene for your residents? For the residents, I've seen facilities that have put the dispensers at wheelchair level, and I've also seen facilities that you can buy the hand wipes in a canister and they can be used for the residents in the dining room. But residents also need to be offered the opportunity to perform hand hygiene after toileting. And the other thing about the ABHR is I would say have a good process. Who is checking to make sure that your dispensers are operational? You ever wonder why the surveyors go up and down the hall and they're pushing on them? That's why. Because if they don't work or they're empty, they're going to give you a citation for that. So also have a process in place to make sure that they're being filled. Most place facilities, give that to the housekeepers and have them check and refill them as needed. This is a poster that comes from the World Health Organization that talks about the 5 moments for hand hygiene. There are many different posters out there, and it is a recommended practice that you post them frequently and at different intervals as reminders for your visitors and your staff. So what your hand hygiene program? You need to make sure that your staff know how to perform hand hygiene correctly, first and foremost. And I believe that most staff that have been in the building for any time, they can, tell you that they sing the happy birthday song when they're doing the hand hygiene and that they can do it correctly. But do they know when to do it? And this is where a lot of the citations are being seen now. And I'll give you an example of that. I read a 2567 for a facility. The CNO the surveyor was watching. It was for the peri-care. So the CNO changed the brief. Then she took her dirty gloves off, performed hand hygiene, and everything's going really well. She put her clean gloves on, she applied the barrier cream, and then she proceeded to, hook the brief up. She pulled the pants up, she fixed the bedspread and the sheet, she fixed the pillow, and then she handed the resident the call light cord, all the while she still had those dirty gloves on. So obviously the facility did receive a citation for F880. So I would recommend that when you're teaching your policies and procedures to your staff, that you check them and do audit them and observe them when they're doing procedures. And we will talk more about this in a little bit. But obviously, making sure that your policies and procedures are current to the best practices that are up to date. CDC, for the most part, is the best source for that. All new hires need to have training on hand hygiene. It's also required annually and as needed. And I would look at your staff. I'd make sure that you provide at different times education to your families and residents. We talked about visual reminders, making sure that the supplies are available, and performing compliance auditing, compliance monitoring, observations, audits. It's all called process surveillance. And then giving feedback to your staff if you find that they aren't following your policies. If you see someone coming out of a room and they didn't perform hand hygiene, you need to say, hey, did you forget something? And hopefully they'll know what you mean. And then obviously you're going to report your different things, your results of your audits to QAPI, and we'll talk about that more as well. More resources here on hand hygiene education and audits. If you need more, any of us on our team will be happy to send more to you as well. And here's just a little graph that we made up for compliance auditing steps. And I think the key here to this is if you're going to have other staff members of your leadership team or any staff member do auditing or observations of staff, you need to make sure that they're competent to do the procedure themselves and that they know what they're looking for and that they know how to use the form that you're having them record the results on. And that way you're most likely to get some good audits and good feedback for how your staff is faring for that procedure. So PPE, which is personal protective equipment, we're going to talk about next. And we have a quick quiz here. If you could put your answer into chat. And it's about when observing staff donning and doffing PPE, which of the following would be the best approach to completing a hands-on competency assessment? If you could just put the letter that you feel is the right answer into chat, please.
We actually have it set up as a quiz. I just posted
okay,
it.
super. Thank you.
Yep. That way it's a little bit more anonymous for everybody because chat's not it's disabled. We only have Q&As enabled today.
Okay.
So far, utilize a competency checkoff list. So they're picking B.
Okay, I agree. Utilize the checkoff list through your observations and provide feedback. And I put privately in there. I think it's really important that we always treat our staff respectfully and that we don't take them away from resident care to do these things. But at the same time, you don't want to wait a week or two or a month or save it all up for an evaluation either. To be effective, it needs to be as close to the time as possible. So what is PPE? PPE consists of specialized clothing or equipment worn by an employee to protect themselves. And not only is it a requirement by CDC and by the State Operations Manual, there are OSHA requirements for PPE use. And PPE also consists of gloves, gowns, face masks, respirators, as well as eye protection. And the goal of all of this is to prevent contact with infectious organisms, substances, so that we can prohibit and prevent spread of infections amongst our population. And I would encourage you to look at your isolation signs outside your residence rooms and make sure that it's very specific and tell staff the type of PPE that they should be wearing before entering those rooms. If you haven't seen these, the next two slides are the donning and doffing signs, posters from CDC. They basically came out with COVID, but I liked them a lot. When I was working night shifts, I admit I was tired enough that I did look at them to make sure that I was putting my PPE on in the correct order. And you could easily turn this into a competency if you needed something really quick to use. And that's the doffing slide. So education and compliance, as with any procedure in the nursing homes, staff needs to be educated. You need to know that they have this basic information. So it needs to be provided at the time of hire. And I definitely, it's the same with hand hygiene, should be more than just having them read a module, watch a video. They need to do a return demonstration so that you or your educator or who's ever responsible for this education sees them doing it, that they do a return demonstration so that you know that they understand, all those little steps that are required and they have them correct. And then again, when they're out in the unit, you need to observe them to make sure that they're still able to apply this information. But think about enhanced barrier precautions. We'll talk about a little bit more later, but the staff needs to know when the PPE should be worn. And enhanced barrier precautions has kind of made things a little bit more complicated. Before, when residents were in isolation, there were no exceptions, but now you're going to need to clarify if somebody's just ducking into the room to, pass ice water, pick up a menu, pick up a meal tray, when they need to don PPE. Top of this slide, I just included the bullet point so that you have that conversation with your staff at a huddle or a staff meeting so that they know how to respond when a resident say, "It's okay, honey, I know you're busy. You don't need to put on all of that stuff." Those type of comments that the residents are going to say to you, or when they say, "Oh, I don't want you to do this." They need to understand that this is to protect them as well as to protect the staff. And it's not optional. The staff needs to wear the PPE. Here is a competency validation form for PPE. It's sourced there on the slide for you, should you want to use that one. As well as we also have some other PPE resources for you to look at. And respiratory protection plans are another basic principle, if you will, of solid infection prevention and control programs. Definitely much more important now since COVID. And we have another quiz here, Jana. You want to put that up for us, please? It's how often should N95 respirator fit testing be completed per OSHA standards? And OSHA is Occupational Safety and Health Administration. So A was on hire annually with changes. B is required only one time. C, every 2 years. And D is only with an outbreak.
So overwhelmingly, we have A, 100%.
A, great. That makes me feel better. So yeah, and that A is correct.
Patty, while I'm interrupting, we had a question come in under Q&A, and the question was about enhanced barrier precautions. Are you going to be getting to EBP later in the presentation today?
Yep, when we get to
Okay.
transmission-based precautions.
So remind me we have a question to talk about.
Okay.
I don't want to forget it. Thank you.
Okay, I will do that. So a respiratory protection plan is exactly what it says. It's measures for facilities to put into place to protect residents, to protect staff, visitors against contracting any kind of respiratory illness. Because there are many things in the air, and most of them we can't see. So, there's viruses, bacteria, and chemicals. And the components of this program include signage, making sure that you have that cover your cough sign up, that we have tissues available, that at the entrances we have ABHR available, we have masks available, that the signs are posted not to visit if you're ill, that, if somebody's coughing, that they're covering their cough, that people are staying as far apart. I know it's not really popular, but 3 feet apart is probably healthier for all of us. And sometimes when I'm in the stores, I still see people, we're not kind of pushing up in the line the way we used to before COVID. We're giving each other some space. And the respiratory protection plans all obviously include the use of surgical masks or N95 respirators and any other PPE that might be appropriate. So N95s, it is a requirement for annual training for N95s. It's also a requirement for annual fit testing for N95 respirators. And before that fit testing can take place, there needs to be a medical screening evaluation done so that the person is deemed appropriate to be fit tested. The fit testing needs to be done, as we said, annually. Most facilities are doing it during the orientation. I really strongly encourage that before they get lost, and not in the sense that, somebody doesn't follow up and get them fitted soon. It needs to be done annually, or if there's been a significant weight loss. There's always the issue out there on facial hair too. A mask really truly can't be fitted properly if someone has a beard. In that case, they have a couple choices. The gentleman can, shave, or some facilities have purchased PAPRs, which are powered air purifying respirators. They are rather expensive, but if a person can't pass a screening, this is an option for them. They do run probably about $1,500, but I've talked to several facilities who have purchased them, and they do use them. The fit testing process, there's materials out there. It can be either a quantitative or a qualitative test. Now, we do recommend that you have several staff members that are trained to do the fit testing. It doesn't have to be a nurse that does the fit testing either. Record keeping is really important. All the medical screening forms need to be maintained in the employee's medical private file, not in a binder, but you're going to need to have a spreadsheet somewhere so you can track who's been fitted for an N95 and who hasn't. And these, as I mentioned before, are requirements from OSHA. But we are also seeing citations now in facilities that staff is not all fit tested. This is just a really nice document from CDC and NIOSH that talks about how to put on and take off a respirator and do a seal check. And here are some resources on respiratory protection programs. Most of them are on respirators and N95s. Are there any questions about N95 fit testing? I know that comes up fairly often. As we mentioned, facilities that are not up to date on their fit testing are being cited, especially if they're having a person with an N95 care for a COVID positive resident and they aren't fit tested. That is another thing. Some staff, they'll say, well, I don't like that mask, but it's not the one that they've been fit tested to. So that's important also, that they understand that the one they need to wear is the one that they were fitted to. And if your provider changes up your products, you're going to need to fit test everybody. And that happens.
How often does the medical assessment need to be repeated?
Annually with the fit testing.
Any other feedback from anybody on that? Okay. Thanks, Patty.
Sure. We are going on now to transmission-based precautions. And transmission-based precautions are used in addition to standard precautions for residents and patients who may be infected or colonized with certain infectious agents for which additional precautions are needed. And I took that right from the CDC. I'm not that smart to craft things that well. But these are things, there are extra steps that we take to protect ourselves and to prevent the spread of infections. And this next here is a grid that we made and put on the website. I did include enhanced barrier precautions in it, although it's officially not part of the transmission-based precautions. Droplet precautions we enhanced on this last update. Droplet precautions in the CDC guidance gets a little muddy. For the most part, they were only requiring surgical masks be worn, but we all know that for COVID-19 and N95, eye protection gowns and gloves are required. We also sourced at the bottom there, Appendix A, for the isolation practices guidelines. It will, if you click on that link, it will take you to all the different infections that are possible and tells you by CDC guidance the type of precautions that are needed. So I'm starting to sound like a broken book, but this requires education. Again, it's annually and on hire. And as with you use any kind of PPE or protections, the audits, the feedback to the staff, and explaining to staff the why behind everything. And I think this is really have been really important with the enhanced barrier precautions so that the staff knows why they're doing the things. They might not agree with them, but at least maybe if they understand the why, things will make more sense for them and they'll be maybe more compliant. We have seen many citations for enhanced barrier precautions under the F880 recently. The first one that we read was for a facility who, when they rolled their program up, didn't look at all their residents to see who might need. You need to make sure that you're looking for the MDROs as well as for the devices that are in place. Several issues in facilities with a process that's seamless so that staff knows when a resident is going in enhanced barrier precautions, as well as knowing when they're coming out of enhanced barrier precautions. In these examples, signs were posted for contact precautions and enhanced barrier precautions, and nobody did anything. One thought that one, didn't apply, and then another case it had been DC'd, but the PPE was still there and the sign was still out and the surveyor's going, what's going on, and the staff didn't know. So anytime those situations happen, the staff and the surveyors especially are going to put their little antennas up and they're going to start digging. But putting a process in place to review all your admissions, making sure that therapy is covered, citations on no PPE at all used in therapy, making sure that your policy and procedure on enhanced barrier precautions is pretty sound. And again, reinforcing with staff, we're recommending that at your huddles, your monthly meetings, you ask the staff what issues they're having so that you can troubleshoot and problem solve together. It's still a learning process, and answering their specific questions. It's back to, in this case, what happens if you have a resident that's in enhanced barrier precautions and the resident gets COVID? You need to be very specific with the staff so that they know that, PPE is going to be needed all the time now, not just with the personal cares. And I think there could be some confusion in those kinds of situations. So here are some resources on transmission-based precautions. And we do have a toolkit there. I think it's the last link on our Superior Health website on enhanced barrier precautions. But now, what was the question, Jana, that you had there?
I think we've got it answered, but the question was about having a port for dialysis and whether or not, if somebody has an external port for their dialysis, do they need to be in enhanced barrier precautions?
I would say yes.
Yes, the CDC did respond to that in their frequently asked questions, I believe, and it is, yes, they need to be in enhanced barrier precautions. So, yeah.
And that document is a really good source to look at too.
And it's always being updated. So I would encourage anybody listening to flag it and put it on your desktop and just check it frequently, or at least once a week. There is an IP, because they are constantly adding, I believe, updating Q&As. We frequently go in and it's new.
So just pulling things together on this part of the presentation.
I'm sorry, Patty, I have another question. I knew we were going to have lots of questions about
it's okay.
Precautions.
We're okay.
Do we have to start EBP on a resident who has a history of MDRO?
Which MDRO, I guess, would be my question.
Yes.
So look at what your policy and procedure says for MDRO. Some of them you will, some of them you won't. Depends on the org.
Yeah, and the community, right? The community.
Yes.
Yeah. greater community around you. So county health department may put out notice or give you information about MDROs that are higher risk in your area.
But it should be it should be determined so that you're consistent in your facility. So that should be a
Yes,
policy and procedure. But if you need some help with
absolutely.
that, just reach out to us.
Yep. Any other questions on enhanced barrier precautions while I have Patty not focused on her slides?
Okay.
If you want, just drop them in the Q&A. It's okay. This is a safe space. No question is a silly question. You guys are dealing with all sorts of complexities out there in the field. You're living this every day.
No, that's the purpose of this series. If we need to, throw something more in on enhanced barrier precautions, we can do that later. Or
so far, nothing, Patty. So I'm sorry.
Okay.
So go ahead.
Oh, no, that's fine. No, I thought that's good. So the next thing we're going to talk about is surveillance. So we have a quiz again. So what is the difference between outcome surveillance and process surveillance?
That's my delay. Let me pull it up, Patty. I'm sorry.
Oh, the poll. Oh, I'm sorry. Yeah.
Yeah. All right. What is the difference between outcome surveillance and process surveillance? And you guys are really quick on this. So far, process surveillance is active monitoring to see if, let's see, it's B. So it's what we're getting. And a few A's, but some mostly B's.
Okay. And B is the correct answer. And we're going to talk about each one of them here. So in general, what is surveillance? And these are a couple of definitions. One's from the World Health Organization, and the other one, I believe I took from the State Operations Manual, but they say essentially the same thing. Surveillance is the data collection, the analysis, and the sharing of important information. This says to the people that need to know so that action can be taken. So basically, you're looking at your results of your surveillance, your data, your audits, your line lists, and you're seeing if something is triggering. And then based off of what you find, you notify the right people so that you can control, prevent, mitigate possible spread. So process surveillance. So I tried to figure out a good way to remember this, but the only thing I can think is process surveillance is practice. So it's the review of practices by your staff directly related to resident care. And the most common one that facilities are doing, or at least should be doing, are hand hygiene audits. So and surveillance is an audit, it's an observation, it's a monitor, it's where you are looking at what staff are doing, giving feedback as necessary, and tracking the results of those observations. It could also be injection safety. It could also be cleaning and disinfection. It doesn't even always have to be in nursing. Look at your housekeepers, your laundry, your dietary. Are they doing, following the correct procedures for getting a tray ready? And that's the purpose, to see if they're following your policies and procedures, because the policies and procedures are the best practices. They are how you want things done. They are the way to prevent infections or injury or any kind of harm. And these should be done concurrently. Concurrently means daily, frequently, regularly. And there is a good source down there at the bottom from the Minnesota Health Department. They have really, really good resources on surveillance. And then your outcome surveillance, that's where you're looking at your numbers of infection. That's where you're going to take your line list report or look at your culture reports, the other things that have very definable and recognizable data. And it's to identify your specific infection events. It could be the number of UTIs. It could be the number of E. coli infections. It could be the number of infections on a unit. It could be infections associated with a staff member. There's many different ways to look at outcome surveillance. But you want to identify any outbreaks, any patterns, so that you can take appropriate steps to mitigate any possible threat, infections, and control the outbreaks. So you can do that concurrently as well as you can do that retrospectively. Oftentimes facilities will do that. Look at short stay and long stay infections, which is a really good way of looking at some of your outcome surveillance. So we have another quiz, Jana.
All right, let me pull it up. All right, I have just posted it.
This resident line listing should include which of the following?
And we are getting, oh, everybody's getting this one, Patty. Number A, or letter A, signs and symptoms of an illness. Yep.
Which I'm glad to see, because at one time everybody thought line listings only needed to record antibiotics. And that's why I worded the quiz that way. So that's great. So your line list,
Patty, I don't mean to interrupt, but we do have a question.
all right.
It says we have our therapists wear PPE for residents on EBP. When they are walking the residents in the hallway, other residents comment they must have something contagious. Our therapists also say that they feel this is a dignity issue. What would be the best response to both of these comments?
Oh, wow.
So 2 parts.
Yeah.
First and foremost, we wear PPE to keep ourselves healthy and to keep residents healthy. And, I would tend to just explain to the residents that enhanced barrier precautions are for everyone, not just for the resident. It doesn't mean anything about the resident. And as far as resident dignity, boy, it depends on the contact with that therapist and the resident and why they're wearing a PPE. Correct me if I'm wrong, Patty. We've had this conversation over and over again. It's a risk assessment, resident to resident, individualized risk based on the amount of contact that you would have with that resident while you're ambulating them in the hallway.
Correct. If you're just, holding onto a gait belt, and you didn't have, and the therapist didn't have to assist them to a standing position, they may not need PPE to walk in the hallway. If it's a person and you've got your arm around them, they need, max assist, total assist of 2, then it is in the guidance. And I think it's just in how the staff's attitude towards it is in some cases. And I agree, you can feel like a dignity issue, but if you still treat them with respect and, you don't make a big deal out of it, I think it will, kind of pass. But if they're, the residents picking up on the therapist's comments, then, I think the therapist perhaps, and maybe I'm missing part of the question here, but the therapists need to understand the intent behind the requirements too.
We're hearing more and more therapy conversations about enhanced barrier precautions and pushback, which is interesting to me. So I would encourage everybody here to do a lot of education with your therapy team about why.
They are part of the team. I know a lot of them are contracted, so they don't maybe always feel that they're part of the caregiving team, but they fall under the same rules and regulations for any other employee in the nursing home, and perhaps don't always feel part of the team, but they truly are an integral part of our team. So thank you for that question. That was a good one. I think it poses a lot of thoughts for a lot of us.
Yeah, and so question again is that they missed the answer about the dialysis port and EVP, and the answer to that is look at your policy. But yes, that is it's an opening into the body. The dialysis port, you should be using enhanced barrier precautions with that.
Yeah, and it was addressed in the EB enhanced barrier precautions, FAQs from CMS.
Yes.
Yeah. And if you don't have that document, let us know, put something in the chat or email us after, and we can be happy to send it to you. So the line list report or log, whatever you're calling it, can be accomplished in many ways. Now there are some add-on programs that are linked into your EMR, your point-click care. I know point-click care has their own infection control modules. Some use Excel spreadsheets, and there's a couple links on this slide to Excel spreadsheets. I was old school and I just had a paper one. So whatever method you use, it's just important that you capture all the signs and symptoms of the resident, that you also include your antibiotic start, You also include any pertinent labs. And what I would say is when surveyors are looking at forms, if you have like 20 different columns, but you're only filling in 16 of them, they're probably going to say that you're not conducting surveillance because you have blanks on your tracking form. My recommendation is if you're not going to use them, get rid of them on your form, get it redone somehow because they're really picky about that. Your line list will help you identify any kind of outbreak, but you most usually have an inkling of as well as you should know what's going on before, you're looking at your line list at the end of the week and saying, oh, I think we've got a problem here. An IP should be able to sense these things before that, but that was the intent behind the line list report, is to track things, look for patterns and trends. You need to have a separate out list for any kind of an outbreak, COVID or otherwise, if you have a flu, whatever. You also need to have a separate tool and line list for your staff. Some facilities call it an illness log. Whatever you do, have something separate for your staff because you're going to need to look at the two side by side to see if you're having any spread between your staff and your residents and vice versa. And then at the end of the month, you're going to look at this list to see which of your antibiotic starts met McGear's criteria. If you're using some of those electronic systems, they're going to tell you it automatically. But remember, those systems are only as good as that you put all of the information in there. If you don't get the signs and symptoms in there or the right information in there, your data may not be relevant. And if you're having a lot of infections at the end of the month that don't meet McGear's criteria, you need to look and see what's going on. So your outbreak investigation and surveillance, I think you're probably all really good at this now. The definition of an outbreak is on the slide here. And it is different for other communicable diseases than it is for COVID. Remember, COVID-1 positive is an outbreak, but in general, for anything else, it would be more cases than normal in an area. And you need to take steps to mitigate that spread, do all the notifications that you need to, and keep a timeline, what you did when and who did what, because at the end, you're going to want to do an analysis of this to see if you learned things. Did you do everything that you were supposed to do? Are there lessons learned? Would you do something different next time? So the role of the infection preventionist is to know what's going on in your building and to work with the team to prevent inspections. You need to maintain those line lists and other reports. And this is just a list of things that I did daily as an infection prevention nurse / DON. You're going to, go to your stand-up meetings, talk to your staff, find out what's going on in the unit and do rounds, give that feedback, check your isolation cards, make sure you have a process for keeping them stocked, do one-on-one education, look at admissions for any potential infection needs. Here's some more resources for surveillance. And then at the end of the month, you're going to want to put all this together. You need to
before you get started on that, I want to just verify something. We've got a couple questions that came into the chat about COVID outbreaks, and that 3 or more cases is an outbreak, 2 or more cases is an outbreak. Your county health departments and your state health departments may be telling you that that's not necessarily an outbreak. And I hate to break it to you, but the CDC and CMS is still stating 1 or more case is an outbreak. So if you have a resident positive, let's clarify this, a resident positive case in your facility, it is an outbreak, and that resident positive occurred in your facility, it's an outbreak, right? So it's different if they admit from the hospital and they have COVID coming in and they go right into an COVID isolation situation. But if it happened in your building and they tested positive while in your care, 1 or more resident is an outbreak. And to the point, Patty, myself, Amy, and Jessica, who work on the TRQII, we work on the COVID outbreaks with facilities. We're getting referrals for 2 or more outbreaks or 2 or more positive residents to work with facilities. So Just wanted to clarify that. Patty, Amy, you guys got anything else to add to that?
There's been a lot of talk about, that they should
Yeah.
change the definition, but to the best of my knowledge, it's not happened yet.
Yeah, and somebody said they just verified this with their regional IP and it's 3 now. We're being told by CMS and CDC that it's 1 or more, that's how they're treating it as an
No,
outbreak.
we can go back and
Yeah, and we can
I'll
look.
let you know next week for sure, but
Yeah.
But when we last looked, that was what we found. So
Right, and I would hate to have somebody get into trouble for not treating it like an outbreak and have a surveyor say, why didn't you go into outbreak?
right.
So,
All right, but good questions. Because I know there is a lot of information and misinformation that does travel about. And like you said, each state's health department and even local health departments sometimes have differing opinions as well.
yeah, and we'll get to that when we talk about, we talk a little bit about COVID and isolation, but staff testing, et cetera. So if you have questions about that, please reach out.
So the month-end report, this is your month-end infection control report where you're going to, look at your line list report and you look at your number of infections. You're going to report out the results of your audits and the outcomes. But what I most want to stress with this is once you have these results, you need to compare them. What do they tell you? For example, if you have UTIs, at 5.6%, and the previous month you were at 1%, you need to do a root cause analysis. Ask some questions, talk to people, and determine as a group what you think's going on, because you need to put some steps into place. This is your next steps, your action plan, whether or not it's doing more audits on pericare. If you need to do some more education, you need to do something. And you need to include that in your report so that the next month you can also report it out. But in addition, surveyors are going to look for this when they look at your reports. They're going to say, well, what did you do? And if you didn't do anything, they're not going to be pleased. So this is the calculation of an infection rate. Really good resource here for you, but it's the number of infections per 1,000 resident days. And then the process compliance rates, just simple math. 45 hand hygiene audits were done correctly out of a total of 50. So your compliance rate is 90%. So at your end of the month report, you need to, analyze your results. Was there transmission between residents to staff and vice versa? And also, I also included anything I did infection control related. Did I give the flu vaccine? Did we do fit testing? What education did we do? Did we get, air purifiers? Did we change? Was there a problem with the dishwasher and we had to, go to paper dishes for a while? Just anything pertinent to your program that shows that you're involved, you're active, and that you're monitoring your residents and your surveillance. And then this report needs to be shared with your medical director, who usually goes to QAPI, which is where this report should go. But if not, I would make sure that he sees it and knows what's going on. And then depending on your organization, oftentimes it'll go through your corporate people or your board of directors. And I would also share pertinent findings with staff. If you're got a big program going to increase your compliance on PPE use, I'd make graphs. I'd hang it up in the break room, make a competition, talk it up, make it a big thing, make it fun. The unit that has the best PPE compliance, gets donuts or something. This is a list of things that I did weekly as an infection preventionist. Obviously I checked the vaccines, reported in the NHSN. I also checked TB tests. We had a problem at one time getting them read, which we did correct by changing how we entered them into point click care, but it's something you might, want to spot check, and anything else that you need to report on. And other monthly tasks, keeping your policies and procedures up to date. They need an annual review. And if you have to provide the staff education, you need to plan that out, meet with other departments and your vaccine clinics. Right now is when you should be getting ready for your flu and your COVID vaccines. Have you sent your consents out? Are you logging them coming back in? Do you have your vaccines ordered? And in summary, surveillance in my opinion, and I believe it's probably pretty much international, is one of the most important responsibilities that you have. It needs to be done concurrently and retrospectively, but even bigger, it needs to tell the story. It needs to show what you have done, and then based on those results, and explaining your analysis, what actions did you take, and if that action was effective in of correcting or improving the state. And if not, don't be afraid to try something else again. That's just all part of quality improvement. But the other thing I want to stress is that it sounds overwhelming, but you need to have the organization's support. And it does take teamwork to be this successful and to accomplish everything. Other people can do audits. It's just not solely the responsibility of the infection preventionist. So we just threw this slide in here. What's on your to-do list? What have you learned? What would you like us to include for the next group, and other things that we could include? And here is the last slide that we're required to show you.
And I just want to let everybody know, I just reached out to the state of Michigan IP that we've worked with quite a bit to see if she's got updated guidance from the CDC on outbreaks, because you guys know more than we do firsthand, but I just know that we are still getting, and I feel so bad for the facilities. I know we all do when we call them to say, you've been identified as having a COVID outbreak, and they've had 2 positive residents. So trying to get our evaluation link. Are there any questions that anybody has, or comments, or things that you would like us to cover next week when we go into?
That was a very high level, very quick overview.
Yeah, there's the survey for this week. Really appreciate everybody jumping on. And
we will send out the slide deck as well for you.
Yeah, I put it in here a couple different places.
Okay,
just a couple things related to COVID, since we talked about it a little bit. There has been a little bit of confusion about return to work for staff. And I just want to make sure that everybody is aware that the CDC, and in their guidance, they have it's a little confusing. You have to look for the return to work for healthcare employees and follow that guidance. To our understanding, that has not changed. You test on if an employee tests positive for COVID, they need to test on day 5. If they test negative, they need a second test within 48 hours later before they can return to work. So hypothetically, day 5, day 7, they can return to work on day 8. If they test positive, they can't return to work until day 10. And we've had some facilities have confusion about that, and we're bringing people back to work on day 5, and you can't do that. So, question that popped up: do you also include days of therapy in your puppy meeting? Yes, we do include days of therapy. I think if that's what you're meaning, like for
antibiotics, yes.
Antibiotic, yes.
I would include, and I think when we come to antibiotics, I think it's on one of those slides.
Yep. We'll talk about that antibiotic stewardship.
I think the other thing on COVID that has come up recently is residents staying in their rooms. Nothing has changed. Nothing has changed on that requirement either, that the residents, are placed, like we said, in transmission-based precautions, droplet precautions, and that they need to stay in their room, preferably with the door closed. Now, obviously, there are occasional exceptions to that, but that should be care planned in much detail. But
yeah, Alicia, you said if negative on day 5 and day 7, then return on day 7. It's 2 48-hour tests apart. Best practice is day 8, but technically it is day 7 that they can return on if negative and symptom free. That's the other part too. They have to be fever free. So, make sure. And is there ever a time you can have staff come back before 5 days? Oof, that's, I would, if you need staff to come back before day 7 to work, you need to talk to your health department, because
that's what I was going to say, local health department. Yeah.
You get with your health department and get guidance from them, and make sure it's in writing that if you're in staff crisis and they are considered essential staff,
and then they would care for COVID positive residents
only. And you need to make sure your policies and your processes for that are tight, because the assumption is that you should have enough staff, right? You should have plenty of staff to take care of your residents. I'm saying that tongue in cheek. So But that's something that you would definitely need to work with your health department on, and I would work with them in writing. So we just test on day 7, can come back on day 8 if negative, otherwise the full 10 days and come back on day 11. No, Lacey, that is absolutely correct. That is the best practice. If they're still positive, unless they're super symptomatic. I know this is where it gets really hanky is IPs, and you need to like look at this risk. If the person is severely immunocompromised and they have like the long COVID symptoms, the CDC does tease that out for healthcare employees. So I would recommend that you look at each case by case if they're still positive on day 7. But most folks that are testing on day 7 are testing positive do 99% of the time they're feeling much better and they're able to come back on that day 11. So I would work with your HR, but that is what Lacey just put into the Q&A is the correct process. It's the best practice process. Any other questions about COVID and return to work? Oh, no open questions. All right. Thank you, Patty, so much.
You're welcome. My
for
pleasure.
attending. We look forward to seeing you next week, and please complete your survey and take care. Have a great afternoon.
Thank you, everybody. Bye-bye.
Bye-bye.